Paul Buckley. I'm the Chief Pharmacist for the Trust, and this morning we've set up a COVID question and answer session in relation to the vaccination. In terms of vaccination uptake in the Trust, we're currently homing in on about 80% uptake, and obviously we'd like that to be much higher. So we've taken this opportunity to set this session up for any questions or queries people have. So thank you for people participating. We're going to start the session off with Dr. Donald Menzies, who's our consultant in occupational health, who will give an overview of the COVID and the vaccination general information, followed by Dr. Amer Hamed, who's a consultant cardiologist, who is going to talk about the benefits and the clinical aspects of the vaccine. And then we've got the ward manager for C3, Paul Begum, who is going to talk about her experience of the COVID vaccine. And thereafter, we're going to have a question and answer session. So on that note, I'd like to pass over to Dr. Donald Menzies. Thank you, Donald.
Thank you. Welcome all. I'm going to talk a little bit about the virus, and I appreciate many of you will have heard through the news and other venues, hopefully a lot of good information and accurate information, but sometimes through other sources, maybe information that is inaccurate. So forgive me for being starting with the basics and working our way forward. I'll head off into talking a little bit more about the vaccine thereafter. So coronavirus has caused a major problem around the world. That's stating the obvious, really. None of us could have predicted the extent of difficulties that it's caused us all, and the sad disease and illness that I'm going to talk a little bit about. Now, coronavirus is something that the medical profession do know a little bit about, because there are some milder versions that do circulate each winter in the UK, and which typically only cause a minor cold. So something's happened to a particular strain of virus that caused it to be much more virulent and much more transmissible and caused the major problems. The current virus is called SARS-CoV-2 to give it its official name, but for the talk I'll call it just coronavirus. It is one of three much more serious viruses that have come out of that particular family. One of them was SARS-1 many years ago now, which fortunately died out, which unfortunately is not going to happen, we think, with this particular coronavirus. And there was another virus that's typically in the Middle East, which occasionally gets to the UK, but is quite a nasty illness as well. So the important part of any virus is that it is made up of a central core, which is the bit that does the harm, and then it has to have an envelope or a way by which it gets into our cells and cause the problem. And the envelope has protein attachments which help it access the inside of our cells. And these vary in shape and size, and it is one way by which we can perhaps attack it. And it's called a coronavirus because in a certain way of looking at it, it looks like the virus has a crown sitting on it. Now, probably the natural host of this current SARS virus was in animals, possibly a bat, and it transmitted to another animal and then into humans and became highly transmissible. The infection comes into us by breathing it in or perhaps swallowing it, and it's entering our system through the bowel. So that gives us a clue as to how we can protect ourselves if that's the route of entry. Once the virus gets into our body, its job, as it sees it, is to just replicate itself and make more virus. But by doing that, it damages our cells. And it particularly affects the lungs, the kidney, and the heart. And that's why we're seeing so many people that are becoming quite ill, and sadly, some dying. It is contagious by human-human transmission, either by close proximity or by touching. It gets into the cell, as I say, by attaching to a receptor. The part of the virus gets into the cytoplasm, which is the manufacturing part of the cell. It doesn't go into the nucleus, which is where our genetics are held, and it replicates, it tricks the cell into making more virus particles, which are then expelled and can pass on to other people with breathing, coughing, singing, that sort of thing. It's got the potential for errors, because what the virus does is it tricks the cell into making lots of copies, as I said, and this transcription process can have a mistake in it. And that then causes a new variant of virus. And that one can either usually be less harmful, but occasionally more harmful. It either transmits easier or is more virulent and causes more illness. And the combination, if you got the two together, would make it a much more problematic virus. So it was, we think now, in late November, we didn't know it at the time, but long before, a month or two even before Christmas, there were some cases of coronavirus that had got into Europe, particularly Italy, but even in the UK, they've measured some blood samples that were taken and stored and found some coronavirus as long ago as November 2019. It spread unchecked because we didn't really know that there was a pandemic already started. And to be perfectly honest, I think China didn't know what was going on and also were rather hiding the extent of the problem. We have seen some main events when lots of people get together that caused a massive spread. And just before we locked down, there were two such incidents, one of which where a lot of Spanish football fans came over and were watching the Liverpool-Spain match. And at that point, many people from England went to watch, of course, and there was a large spike in infection following that. And there was also a large group of people that got together for horse racing festival at Cheltenham, and that too spread a lot of virus before we locked down almost a year ago today. Now, just to set the scene in terms of the seriousness of what we're talking about, I had to look at some figures at the beginning of this week, and they will unfortunately have gone up a bit since then, but sadly 126,000 people have died in the UK with coronavirus. And that makes current situation on Monday, 96 new people died on Monday with this illness. The total number of cases that we've had in the UK is 4 million, which makes, again, Monday, there was 5,600 new cases still per day. And in terms of the number of people in hospital, there are 6,000 people in hospital with coronavirus on Monday. That is less than before, which is great, but it's still a lot of people quite seriously ill, and a proportion of those people sadly won't make it out of hospital. Now, okay, so what's been done about that? And the figure that again was for the beginning of the week, well, there was about 27 million people in the UK that have been vaccinated, which is great. And more will have been vaccinated since the beginning of this week. So we started off treating the virus or trying to manage it by saying those people that had a certain number of symptoms should be tested and go home and isolate themselves. Now, unfortunately, we now know that about a third of people will have the infection but not have symptoms. So that group of people will have still been allowed back in a year ago to still come to work and travel and meet up with others, and they would have risked passing the virus on. But we've learned a lot since then, and we now know that it's possible to have the infection without realizing it. And that's why a lot of occupations are now doing regular testing to identify it present in people who haven't yet got any significant symptoms and advise them to have further tests and go home and isolate. But that means about 2/3 of people who develop the virus will be ill with it, and some sadly quite seriously. I think most people have seen what's been on the news and how it affects you, so I won't go into that in any major detail. But there are post-viral symptoms. Some people are calling it long COVID if it lasts a long time, of anything up to 3 months or more. And the main problems there are fatigue, shortness of breath, and palpitations, which is where you feel your heart beating fast. These are unpleasant, and maybe up to 10% or 1 in 10 of us will be troubled with this if we catch the infection. So all the more reason to prevent it. It's not just that as a younger person you might catch the infection and pass it, get through it quite easily. Up to 1 in 10 of you will be having problems and needing to spend time off work and feel miserable with it. Obviously, it can cause a serious illness, as I say, and we won't go into that further. There's several ways, therefore, that you can prevent infection. And those are things that we've been all trying to do lately. We've been wearing masks to stop the respiratory spread. We've been washing our hands more or using the gels to decontaminate, because if you're breathing out, speaking loudly, or singing, or making any respiratory efforts, you will be expelling some aerosol which may contain virus. So it's important that to understand that to an extent, some of the area around about you, your workstation or at home, will potentially have little droplets of virus on it. So you might think, well, how do they get inside me if they're landing on the surface? And the answer is that your hands are touching surfaces obviously a lot of the time, and then you bring your hands up to rub your eye or mouth, and that's when infection can spread by you getting it in your mouth and swallowing it. And you might think, well, I don't put my hand up to my mouth that often without washing it first. But if you actually spend some time videoing somebody who doesn't know you're videoing them, about 60 times a minute, they are actually bringing the hand up to their face to wipe it or to brush it or scratch an itch or put something in their mouth, such as a sandwich or something. So that's the way it seems to get into your system that way. The other thing that can help us prevent the infection is by keeping a distance from people. If there is going to be a little bit of a virus droplet or an aerosol, it will drop to the ground within about 2 to 3 meters. So if we keep 2 meters away, that reduces our chances of catching that aerosol. The other way, of course, is the the vaccine, which we'll be talking a little bit about, firstly myself and then Dr. Hamed. So just to talk a little bit about the virus a bit further first before we go on. Now, virus has affected different people differently. So from the first wave, within the first 6 months, so the summer of 2020, it was obvious that people from different minority ethnic backgrounds were disproportionately affected. And we really didn't immediately know why that would be. Further studies have found that they have a higher likelihood of catching coronavirus, that they seem to have a higher mortality from that illness, and often once they got into critical care, they had a poorer outcome. Now, we need to consider how has this all happened, and it's probably quite a complicated picture. There are some pre-existing conditions that people will have that are going to be present at different amounts in different races. And these may help the virus attack them preferentially, as it were. Being a little bit overweight or obese is a risk factor, and that is going to be common in some groups. Diabetes, again, common in some BAME community groups, is another risk factor for this condition. And existing cardiovascular disease is also a risk factor. And again, it is going to be prevalent in some groups more than others. I think initially, perhaps when you saw the television and other programs talking about the pandemic, we wondered whether people with chest problems such as asthma were going to be particularly badly affected. And that has not proved to be the case as we go along. So it's not in that way like flu. It's not as mild as flu. It is a serious condition that affects people more so with pre-existing conditions. And those are more common as we get older, which again is why the older age group have problems. There's quite a complex interplay of social, economic, biological, and pre-existing health risks that's going to vary across different ethnic groups. Firstly, some people are going to clearly be more exposed to other people in the nature of their job, or perhaps the way they live. And so people in transport, in security, in healthcare and social care are going to be more exposed to people and therefore more exposed to infection. There might well be differences in their immune responses. In some people from countries such as Africa, if you have a very strong immune system, it may be quite beneficial to protect you historically or over the generations from TB and malaria. But actually, having a strong immune system actually may overplay in this condition, and it may cause more damage, almost the body self-damaging itself when it gets a COVID infection. The environmental conditions that we all live in are going to be different. Some people living in busy town centres are going to have more pollution from cars, or if you live near a big factory that's pumping out air pollution, and that will maybe differentially affect different people in different groups. Some people seem to be more likely to go on and actually develop the disease in a bad way, depending on, again, different ethnic groups too. And we don't fully understand that. I think that's fair. We're still working away at trying to understand that, but really we need to do something about it as soon as possible, and look at ways that that can happen in a minute. So we have identified that certain people with different receptors on their cells, which seem to allow the virus into the body, might be more susceptible, and some people from African background seem to have more of these receptors. People with blood group type A seem to be more at risk than some others, and again that will be unevenly distributed in different groups. We need to also consider that some of the risk factors may be modifiable. So people with underlying health problems that may be out of control or not optimized, such as diabetes or being overweight, that can be tackled and your risk reduced. People who might be rather shy to or don't know how to easily access health services can be assisted to get better access and improve their health, and also seek help earlier. And lastly, vitamin D replacement in the UK. Through the summer months, we may just about get enough vitamin D enhanced through the sunshine exposure, but through the winter, all of us don't get enough vitamin D. And that may be true also if you've got darker toned skin, you will have less likely benefit from sunlight. And so we are recommending vitamin D replacement for the whole population through the winter, and probably all year round for those from the BAME community. That's just an effect, unfortunately, of the Manchester weather. So in the long term, we also need to look at people's housing, how we promote health, how we educate people, and how we look to provide better protection in the workplace. And some of these things are already happening, but more needs to be done in the future to prevent this problem, because it's not going away completely. It will still live with us for some time. I want to briefly just talk about the vaccine before I hand over to Dr. Hamed. So the vaccine has been a UK success story, and I'll talk a little bit more about the actual vaccine in a second, but I just wanted to talk about the numbers, because I know some people are hesitant and say, well, I'll wait and see what's happened to some others who've taken up the vaccine before I take the leap myself. Half the adult population last week had received their first dose. That's nearly 27 million people from beginning of December, when the vaccine program started, to the end of last week. There are about 53 million adults in the UK. 2 million of us have had our second dose now. Most of those doses have been given out in primary care, but we have had hospital hubs that you'll be aware of, and other mass vaccination sites. The good news is that 95% of people over 60 have been vaccinated already, and we know that age is one of the biggest risk factors, so we are doing a lot now to protect the older population, those in care homes and those that look after people in care homes and in healthcare. Now, in April, we are continuing to vaccinate our healthcare staff and others in the care settings, and 12 million people are expected to have their second dose in the next month or so. So the UK has bought millions and millions of vaccines for the UK and for its overseas territories. It's bought 40 million Pfizer, 100 million Oxford vaccines, Moderna 17 million, Novavax 60 million, other ones I won't name, but they're there. And the purpose of buying this number is to make sure that we all have plenty of vaccines of different types, and we can also share them with other parts of the world. These vaccines have been through very robust trials, and people say, well, how can it be produced so quickly in about 9 months from the first diagnosis? And it can be, if it really needs to be, if people work together all the way through in parallel. So normally what happens with a vaccine, a company will work on it, and then once it's fairly happy with its production or its science, hand it over to the regulators. But what happened with this vaccine is that there was the regulators involved from very early. We have a very strict regulatory system in the UK with the MHRA, the Medicines and Health Products Regulatory Agency, and they have signed off the 3 vaccines now in the UK, and they're looking at another 2. The three that they have signed off is the Pfizer, Oxford, and Moderna vaccines. The Moderna is very similar to the Pfizer vaccine. So just talking briefly about the vaccine itself, there are lots of different ways that you can make a vaccine, but the 2 that are currently available, which makes sense to talk about, are the Pfizer and the Oxford. Just briefly, the Pfizer takes a bit of the RNA, which is the part of the vaccine that codes for the surface of the vaccine. So it's not a, if you like, it can't make vaccine. That is wrapped in a fat or lipid layer and injected into us. It has to be done by a syringe into the muscle. That gets round the body, the cells take it up, and they make the surface of the virus against which your body then says this is foreign and fights it off. The same is true for the Oxford, but they use a different mechanism where they inactivate a virus, put the spike protein in the middle, and then inject that, and it's through the virus that it gets into the cell. The virus is damaged, so it doesn't live long, and it can't then cause an infection, but the body's delivered the spike protein against which it produces the immunity. So overall, we have in the real world data of these millions of people being vaccinated, evidence of a highly effective vaccine, which is bringing about 90 to 95% protection in the older groups. We know about that because they were the groups to have it first. And they were the group that we might worry about that were going to be hospitalized and die more likely than some of the younger groups. But if it works well in the older groups, it will definitely work well in the younger groups, and we have evidence of that as well. So I would say to you that we have a good vaccine or a series of vaccines, and there is talk now of expanding that vaccine program to potentially have further doses to protect all of us or some of us that are more at risk. And there's talk even of vaccinating children now to protect them. So I'm confident that this is an effective program that is safe in the sense that it only causes minor side effects in terms of 24 hours, 48 hours of sore arm, or just feeling off color. Now, with any vaccination, you are going to have some people that will have a reaction, but really there are very few people that cannot have one or other of the vaccines. So I think I've talked enough, and I'm going to hand over to Dr. Hamed now to talk a little bit more about the benefits of the vaccine. Thank you.
Thank you very much. Very nice presentation and informative, and I hope we all get much benefit from it, and that give us the basic information about the virus and how the disease get to us, and what's the available vaccine. Now, why we need the vaccine, my point of talking. Now, normally when we have the infection, we got immunity from the infection, but that immunity is not that great and doesn't last long. So having the vaccine is important to secure more that you got more immunity to the immunity that you already had, even if you had the infection, obviously, let alone if you don't, like most of us who haven't had the infection so far. So having the vaccine is important because the vaccine, as shown to us early, then the vaccine get into the cells either through the stimulating the shell of the protein of the virus to the body immune system, or the AstraZeneca one, which introduce a weak virus that is not harmful to the body, and then the body and that virus contains the shell protein so that the body immune system recognize that shell protein of the virus, thinking that the virus is there and producing immunity. So either way, whether it's the Pfizer or the AstraZeneca, the body will start building immunity by forming antibodies and cell that is fighting the virus. So it's important that we take the vaccine, and the vaccine will augment our immunity. Now, roughly the immunity of the virus so far can last a few months. We don't know how long, it's still studies about it, but it's probably a few months. Now, if you have the infection, probably it's advised that we don't take the vaccine within a month. That's just to allow your immune system to improve and settle before you will get the vaccine. So anybody who got the infection, the COVID infection, himself or herself, need to wait for a month before they get the vaccine. But it's important they need to get the vaccine. Now, what the vaccine do, the vaccine, as we said, it's get into our immune system, produce the antibodies and produce cells that fight the virus. So the body will have another boosting immunity coming on the top of the virus if we have the virus already, or if we don't have, then the immunity will start kicking on and give us support for our immune system to fight the virus. And as said, although the virus is in the majority of cases, something like 70 to 80% is mild and will be manifested as a simple flu-like illness, but there is no guarantee that it will not be a severe one, even sometimes in young people. And unfortunately, although this starting of the pandemic was mainly elderly and people with many debilitating conditions, or what you call it chronic diseases like diabetes, like high blood pressure, heart failure, and immune compromised people, cancer, it's now getting more on younger people also. And we can see people in intensive care who are in 40s or 50s and 60s and in some areas of the country, which is alarming. Now, the good news is that because now we started the vaccine and we are now approaching half of the nation to be vaccinated, we need to try to continue that effort, because the more we vaccinate people, the more that the immunity will be built in many people, and the virus transmission will be reduced and will become copable, or the immune system of the body of most of the people will be handling it, and that's as a nation, the NHS will be coping with the burden of too many people admitted. Because if we don't, i.e. if we don't vaccinate ourselves, there'll be more and more people infected more, and sometimes we'll have like a local outbreak, like what you can see nowadays. You can see now in the last few days, Italy cases surging again, some cases in Europe coming back, in Germany, in other parts of the world, in spite of things cleaning up. So there's no guarantee that the virus will not become active again if we are not securing ourselves as a community, as a countries, by vaccinating as much as we can of our population. And the number is suggested is probably something like 80% of the population. If we have the people vaccinated, then at that level, beyond that level, the virus will be copable, and we can manage it as a community, as a NHS, as a country. So the virus, taking the vaccine is very important for us to build our immunity. And when we build our immunity, then we can handle the virus. Even if we get it, at least we will get benefit that we will not die, because all the vaccine prevent death from the COVID-19 infection. While if you don't vaccinate, there is no guarantee that you'll have a bad one, and you might end up one of the unlucky one who have the 10% bad disease, and some of these might end up in intensive care and some might die, unfortunately. So please take the vaccine. The vaccine is very important, and it is important even if you have the infection, let alone if you haven't had COVID infection at all. I think this is a remark about it, and we will do more on the question and answer session. I think I stop here and to my other to the next talker, please.
Hello, everybody. So my name's Begum, and I am a senior sister working on a medical ward. So the reason why I decided to take the vaccination was not only for a professional reason, but also a personal one as well. So during the first wave of the pandemic, which was March 2020, I was actually on maternity leave. So during this time, I lost a few family members and close family friends through this virus. This has been an extremely emotional time, as not only was I dealing with having a newborn baby to look after, but also on top of that, I was also dealing with a lot of grief. So that was really, really difficult. And on top of that, I've also had to cope with the anxiety and the stress of having work colleagues go through COVID and giving them the support, even though it wasn't in person, but it was over the phone and via text messages. I remember thinking at the time, whilst I was at home, just hoping for this vaccinations to come quickly. I was reading all this on BBC News and TV about, you know, the vaccination will be a cure to end this. We just really, everyone wanted to hear, you know, when this is going to happen, so we can all have our lives back to normal again. So when I returned to work in November 2020 last year, I remember receiving a phone call on C3, of which I answered. The person on the line said, if anybody on the ward wanted to have their vaccination, then 2 people can go to Pinewood immediately. So what I did, I asked the members of staff on the ward who were working at the time whether they wanted to go, and they refused for various reasons. Myself and the ward clerk rushed really to get this done. For me, at the time, there was no second thought about it. I was having this vaccination. This was the first step for getting our lives back to normal again. I knew at the time I did the right thing by taking the vaccination, because I was keeping myself, my family, my friends, my colleagues, our patients and their relatives and everybody else safe. I really suggest and plead to everybody, please, if you haven't had your vaccination, then please get this done. It is the only way to get our lives back to normal again. Thank you. I'll now take you to, I think Anelia will be going to ask some questions to the team. Anelia?
Yeah, well, we can open it up to the floor now. If anybody has got any questions, you can either unmute yourself or put it in the chat and then address it to any of the panel members that you want. Does anybody have any questions?
Hi there. I guess my question is just that it's definitely obviously weighing up the benefits of having it against. For me, I'm just generally scared of all medication. I don't take any medication at all, and I guess with this particular situation, I personally don't have any risk factors at all. So far, I've been thinking that, from my personal point of view, that to not have it, because and people who have got a risk factor, if they've got if they have the vaccine, then it doesn't really matter if I do or not, because if people who want to have it can have it. And I guess that's my question, is I guess I'm just concerned about long-term effects, which and I personally in the short term probably haven't got any risk factors.
That's a very good question, thank you. And it is something that we have heard similar. So I don't know if one of the panel members wants to take that, but some of the feedback that we've had from colleagues is that if whoever's had the vaccine is protected, so somebody like the caller that's just had the question, if she doesn't have the vaccine, obviously the implication is to herself, but not to others. Who would be happy to answer that one?
Can I answer, please?
Yes, please, Dr. Hamed.
Thank you for the question. A very important question. And I think most of us, yes, think that we're young and we can have, why we don't need the vaccine. Now, the vaccine is not a medicine. The vaccine stopping you getting ill. Medicine treating you when you are ill. So the vaccine is different from the medication. That's the one point. And the statistic that we, in the world, the vaccine prevent 2.5 million deaths per year, just because the people are vaccinated. And we've seen from the history, something like smallpox, polio, measles, all that, some of them eradicated, some of them reduced to very small cases because of the vaccine. So the vaccine is very important and very vital to be taken, even if we are young and healthy. Second point is, as I said, that even if you are healthy, you still need the vaccine, because you cannot guarantee that you will not have the infection, and you will not have you will not be one of the 5% who are got bad disease and then might end up in intensive care and might not survive. So please take the vaccine, because it's the only way. There is no treatment for this virus, unfortunately. There's no cure. The medication we're using is like a partial cure. So steroids and other stuff that is now, it is not ultimate cure. It's help prevent death by a certain percentage. Like the steroid, the dexamethasone is around 50% reduce the mortality, the death. But there is no ultimate cure. The only way to try to stop you from dying with COVID is the vaccine. So the vaccine is very important to take, because that is the only way we can improve our immunity and prevent ourselves from having a bad disease or bad COVID.
May I make an additional comment? I think it's a good question and it's valid. I think the coronavirus, as I've perhaps indicated in my earlier talk, is not going to go away. It's going to continue to circulate in the UK, but also around the world for the next few years. So really, in the course of your life, you are going to be, in the next few years, going to be at risk of exposure to it. And we've heard from Dr. Hamed that you're playing a bit of a roulette game there, that you could be one in 20 chance that your particular version of the illness is quite severe. And once you get into hospital, have to go into ICU, the odds are maybe of the order of, and I don't know the exact figures, but it's about 30% of people will not make it out of the ICU because of very severe illness. We have an effective treatment. It will cause, in many people, some mild symptoms in your arm, maybe lasting 48 hours, an ache and a pain that's moderate, that's eased by paracetamol. A proportion of people, a smallish proportion, but a significant number, will also feel off color for probably two, maybe even 3 days, that you might feel, oh, I'm coming down with something like a heavy cold or something like that, may even feel quite feverish and a bit shaky. A small proportion of people do feel like that. And in that situation, that again will pass and just would give that group a tiny little taste of what it's like to have the full-blown infection. But it's nothing like the full-blown infection, which really sort of poleaxes you and you're breathless, you can't catch a breath. You will also have the risk, if you caught it even relatively mild, hardly knowing it's there, which is a possibility, and then be followed up after about a couple of weeks. Some people then feel so dreadful for maybe anything up to 3 months, and maybe even more. I've got 1 or 2 people, sadly, who are still feeling that way after 6 months. And they struggle, they're breathless on climbing a flight of stairs, or even just trying to get dressed in the morning. Some of them are feeling very achy, just exhausted, and feel like, you know, life's not worth going on with as they feel at that time. So we can't predict who might be affected either seriously or have this, what we call post-COVID or long COVID illness. And for those that have caught it, it's really quite disabling. Obviously, we can all catch the infection. Most of us have never met it before because it's a new brand, if you like, a new variant of a coronavirus. And we will succumb to it if we haven't had the vaccination, and during that period of 7 to 10 days you are quite infectious and you will pass it on to other people who haven't had the vaccine either. And if you're obviously in contact with people with susceptibilities, they will succumb to it. And maybe there's a few people, not many, who can't have the vaccine or are against the idea for some other reason, and they are then going to remain susceptible for a few years anyway. And you would be then in a position really of passed on that infection. So the more people that have had the vaccine, the more likely someone who you might meet who actually has the infection that will not pass on to you or anybody else who's had the vaccine. So it stops the transmission generally for the population as a whole, for friends, family, colleagues at work, children, others in the family, really. So I think it's of value to have it personally, but I would also say that there is a wider benefit for friends, family, colleagues, offspring. And just one final part about the risks of having the vaccine. There isn't a vaccine that I'm aware of that would likely or potentially cause, if you like, long-term effects that aren't obvious when you first get it. It's very rare, let's put it that way, for you to have a vaccine and then, let's say, 6 months or a year or 2 years later to be unwell because of it. That just generally does not happen. If you're going to be unwell, it's often in the first few days. You recover from that and you've developed the immunity. There are a few people who will have slightly longer problems, but they are few and far between. And when you compare that against the likelihood of dying, then it's small risks, I would say. The estimate in France, they've delayed for a week because they were checking the Oxford vaccine, and probably there are quite a number of people that will die as a consequence of them temporarily halting their vaccine program while it was looked into. So they had to weigh up the risks there. Do we carry on, or do we halt it and know that people will die as a consequence of us halting the program? And they made the decision to halt it, which is their choice. But I know that as a consequence of that, a certain number of people, tens, maybe hundreds, have died because of halting the program. So it is a risk balance, which we accept. Nothing is perfect, but actually the theoretical idea of oh, I might get a side effect or a problem later in life. There's no other vaccine that I'm aware of, and obviously we're vaccinating people against lots of things in occupational health and for travel. There's none that I'm aware of that would likely do that. So I'll stop talking there.
I think I would echo those responses. I mean, I'm a pharmacist and I don't particularly like taking medicines, but I think, I mean, I've had the vaccine. I've seen colleagues really struggle who've caught COVID, and also the longer term implications of it. And I just don't think it's worth the risk by not having the vaccine on a personal level.
Does that answer your question?
Yeah, very thoroughly. I've got to I've got to try and work at the same time, which is but I've definitely listened to everything, and some like very good points. That as you say, everything is a risk balance, isn't it? But this, yeah, everyone's made some really good points. Thank you.
Anila, can I add something on that risk? Just
Yes.
from a statistical point of view, actually, you are obviously, you're right. We cross the street every day. The chances of hitting by a car is there. So the chances of long-term, just on that side, long-term severe side effect is very rare. It's 1 in a million. That is less than the chances of a plane dropping on your house and killing you, which is 1 in a quarter a million. So your home is more risky than having the vaccine. Staying at home is more risky. That's a pure statistic.
Yeah.
Well, thank you for your questions. If you've got any more, again, please just feel free to unmute. Is there any other questions from any of the other callers online today?
Yeah, I've got one. It's a bit of clarity. So I think I'm misunderstanding. Has the Pfizer and the AstraZeneca, does it give you a little dose of COVID, albeit incredibly mild? Is that right? Am I misunderstanding that, or is that correct?
Can I start by answering that? No, it doesn't. It doesn't give you any of the COVID infection. What it gives is a little strand of instruction called an mRNA, which instructs the cell to produce a protein which mimics the virus, and then the immune system learns about what it is to have this in your system and fights against it. So the quick answer is no. The vaccine of the types that we're talking about do not give you a little bit of the infection at all. It gives you a mimic of the outside coating of the virus. There are different types of vaccination, some being used in China, some in Russia, which are a different model, and they might include a virus that's been damaged beyond repair and injected into somebody to generate an immune response. That one works quite well as well, but that one might just be along the lines that you were thinking of. But the Oxford and the Pfizer and the Moderna, which are both sort of, all three of them are in the pipeline for the UK imminently or now, do not actually introduce any part of the virus as such.
Okay, great. Just as a second question, I suppose, I think my big issue is long term. So I understand the benefits of having it. You know, I'm not against, I get my flu jab every single year. You know, normally I would be first in line. I think it's just the speed that this has happened, and nobody knows what the effects of having the vaccine are, not COVID, but having the vaccine. And I think especially at the beginning, there was a lot of and ahhings about women's fertility and the vaccine. And I'm just a little bit, I don't particularly want to put something in me that could affect fertility or anything else going forward. And I think that's my big issue. And as I said, long term, you know, I suddenly don't want 53 million people to drop dead in 12 months after having the vaccine. I'm not suggesting that would happen, but I just think it's the speed that this has all happened, you know, because any other vaccine takes years and years to develop. And I understand, Dr. Menzies, that you mentioned that at the beginning. I just think it's just the speed that's making me quite unnervy, to be honest.
Can I respond, Anila? Yeah. Now the vaccine, as Dr. Menzies is telling us, because the corona family of viruses was there before, so we had a chance. The scientific community for the last 20 years have been doing research on coronavirus. Obviously, it's not this one, but the previous generation of the same family. So it's not new. The scientific work has been there for ages about it. The virus is new, so they adjusted the sequence of how the virus is produced. So, and the other causes is that because it is a pandemic, as the WHO put it, which means involving the whole world, there is a global scientific and, more importantly, political will to combat it. Beside the government, which, as you know, in every part of the world, got the money, so they ask the companies to go and do research, and they guaranteed that they will take the vaccine from them. So that's why, with all these guarantee for the scientific community and for the drug companies to produce the vaccine, this vaccine have been done, instead of having the stages done 2-3 years, every stage of the vaccine production, which is usually 3 stages, and the 4th stage will be delivering it. That was done, instead of one after the other, it gone in parallel, so the same time. And the other bit is that because it's pandemic, there is thousands and thousands of patients available, while other diseases like Ebola, there was few cases only in Africa. So to have a vaccine, it needs a lot of months and years to collect enough data to do it. While here, it was only 3-4 months was enough to collect thousands and thousands of cases. And this that Dr. Menzies that we have here so far, the vaccine, which is AstraZeneca, Pfizer, and Moderna coming, they have 100,000 patients tested on them, 100,000 between all of them. So I hope that this will be a good advice for you. Now, the other bit regarding which is a very valid point about fertility for ladies. Now, this is remind us of a sad story, unfortunately, with the measles stuff. Because with the measles stuff, unfortunately, I'm a doctor, and one of us doctors has raised a concern about a measles vaccine and caused a trouble. And we don't want to name people here, but he's known, and he was stuck from register because that wasn't scientifically proven. And that end up that the measles vaccine, there was doubt in the families, and measles vaccine uptake was reduced, and we have a resurgence or recurrence of measles in UK, which is not very well disease, obviously, and can cause a lot of problems. So the same thing here. This is the concern was raised by one German scientist, and that haven't been proven. It's just a speculation, and there is no research that do that, and that scientist was talking about something called anti-Synaxine-1 antibodies that could be affected, and research after that did not prove that. So this is unproven worry about fertility, and the Royal College of Gynecology and Obstetrician have issued a statement about that although the vaccine was not tested on pregnant ladies and children, like all drugs and vaccines, because as a safety measure, once the vaccine is now given to people, now it's the Royal College have weighed the benefit and risk, and they advise that if you have the risk as a lady, whether a pregnant lady or a lady in general, and worried about your fertility, if you have the risk, like you're being a diabetic or having certain diseases make you on the risk factor, then it is advisable to take the vaccine, but you have obviously to consider that, talking to your GP and your specialist on that field. I hope I answered your question.
Yeah, you did. I have got one more question. Sorry, I feel like I'm hogging. So I actually had COVID at the end of January, beginning of February this year. As you can see, I didn't die, so that's a good thing. So I think my question is, what's the difference between what my body is now doing? So I'm guessing my body has now created antibodies against COVID because I've had it. What is the difference between what my body has produced on its own versus having a vaccine? Now, I'm not suggesting people should wait until they have COVID. I was very, very lucky in that I was unwell for a few weeks and then I'm absolutely fine. But for me, on a personal basis, what's the difference between what my body's done versus the vaccine? Sorry, I feel like I'm hogging, but it's just a great opportunity.
No, not at all. Honestly, your questions are really welcome, and this is the whole point of the session. So I'm sure one of the panel members will be happy to answer.
Well, you're on mute, Dr. Menzies.
Yes, I'm going to answer briefly your first question first, if I may, about fertility. It has been very well addressed by Dr. Hamed. The vaccine idea and the development was very quick, and it's been explained how that is. It's the same technology as they used several years ago for the Ebola outbreak, which was effectively controlled. So that idea of the vaccine goes back several years, that technology. And the other thing is that I'm not aware of any vaccine that affects a lady's fertility. So the idea of a vaccine of any type of the ones that we design might affect fertility. That's never happened going further back. So we shouldn't have any particular reason to consider that it will do going forward.
I think it was, Dr. Menzies, I think it was right at the beginning when the trust started offering. I think they've now removed it, but the comment was if you're pregnant breastfeeding, which I understand, but it was also if you are planning on becoming pregnant within the next few months. And I think that's what caused a lot of, does this mean that I'm not going to be able to fall pregnant because I've had the vaccine? So I think it wasn't necessarily the pregnant and breastfeeding, because as Dr. Hamed said, you know, safety measures, they wouldn't test it anyway. I think it was that comment of, if you are planning on getting pregnant in the near future, I think that's what caused a lot of concern.
I'll talk about that very briefly. I think the government were launching this huge vaccination program that was obviously going to be for all adults in the UK, the 53 million of us, and it wanted to make sure that it rolled, you know, that everything rolled very smoothly, and that it ran without any problems and no queries or delays or scares. That we didn't need that at the beginning, because it would cause people worry, and so that's why they, in my opinion, brought in these precautionary steps for the vaccinations. They wanted to get it off the ground, running smoothly, check it out with the general population, and then they've added in the people that they thought, well, might be more susceptible or might be more worried about their status. In America, they are giving the vaccination to pregnant ladies. Certainly in many states. I don't know whether it's all the way across the US, but it is being given to pregnant ladies. They made that decision on their information. We decided that it would generally be not recommended, because we are on a precautionary basis. But there's one or two pregnant members of staff that have decided their risk of catching COVID and losing their pregnancy or being very seriously ill themselves meant that they wanted to have the vaccine. So there's a few staff that have weighed up the pros and cons, talked it through, and had the vaccine during pregnancy. That was the situation with flu until fairly recently. We weren't generally encouraging pregnant ladies to have the flu vaccination, and then we realized that actually pregnant ladies are much more susceptible to flu vaccination. A few of them were sadly very seriously ill or indeed dying of flu, and so we switched it around, and pregnant ladies are now encouraged to have the flu vaccination. They're one of the higher ones that we're trying to get vaccinated. You raise a second question, so I'm going to go into that. The evidence that I've seen is that catching coronavirus would give you 60 to 70% protection. And as Dr. Hamed has said, we're not sure how long that lasts. We think it'll be months, maybe a little bit more than that. And the coronavirus vaccination, however, is giving you 80 to 95% protection on 2 doses. So the vaccine has been specifically designed to encourage the immune system to produce the immunity, to prevent you getting the infection in the first place, or if you did catch it, it's going to be very mild. So the vaccine is more effective, unusually more effective than actually catching the illness in many people. And what we are doing, if you've caught it, is recommending at least 1, probably 2. The standard approach is 2 vaccines afterwards to boost up your immunity to its maximum. Yes, catching COVID usually gives you protection. It's slightly less than we get for the vaccine. Some people may not, if it's a more mild illness, produce so much immunity. But we know that the vaccine, in lots of different age groups, racial groups, those with underlying conditions, provides between 80 and 95% protection. So it's better to have the vaccine as well. It's the bottom line. Somebody else may jump in with additional comments. I'll stop there.
Yeah, I think I'll just add on the point of the infection. There is some new research in the last, I think, few weeks that this is the point that Dr. Menzies now, if you got the infection very mild, it means that the viral load, the amount of virus you got is not a lot, and your immunity is not a lot. So that's probably, you will need definitely the vaccine. Obviously, everybody needs the vaccine, whether you got it bad or mild, but the milder one might be more, they might have the infection again, and they might have it badly this time. So definitely the vaccine is need to be addressed and taken. I hope I answered this question. Any more question?
Yeah, thank you both.
I was just going to ask, I guess now in the trust, there is only the choice of, well, now it's the AZ vaccine rather than the Pfizer vaccine that's.
Yeah, is your question in terms of which one is available?
I was going to say, all my colleagues have had it and they've had the Pfizer one, but because I've been hesitant, my understanding now is, is that it's the AstraZeneca one.
Yeah, there is a question on the chat actually
Okay.
that is asking as well, similar to yourself, is there a choice? Can people opt for one or the other? And also on the chat, it's just mentioned that there's a requirement for the AstraZeneca one, so you've got to have allergies. Can anyone elaborate in terms of choices from the panel?
I think I wouldn't like to say we get what we're given, but effectively you get what you're given. It almost as simplistic as that. We are allocated vaccines initially as a trust because we were vaccinating lots of people. We were given the Pfizer vaccine, and the reason for that is that it comes in effectively. It's almost like a pizza box full of vaccines. When you defrost there's nearly 200 vials in a box. You have to use the box within 5 days. So it really lends itself to using that particular vaccine in large areas. So we were allocated the Pfizer vaccine on that basis. And the critical thing thereafter is, once you've given the first vaccine, the Pfizer vaccine, then you should, the second vaccine, use the same brand, if you like. So because we were using Pfizer vaccine as the first vaccinations, then we will be definitely given sufficient supply for our staff to have the second vaccine as a Pfizer vaccine. But there has been recently, though, changes in terms of so in terms of the amount we've got in the country. It's almost like a cut-off then to say that's the amount of Pfizer you're getting, and therefore in terms of going forward, we've now got the AZ vaccine, which has particularly been commonly used in primary care, but is now started to be released in secondary care as well. So we don't really have a choice in what we can have. So going forward, because we've vaccinated lots of our staff now with the Pfizer vaccine, and because we have no longer further supplies of Pfizer vaccine going forward, it will be the AZ vaccine we're using, and we have a process now where staff will obtain that via Occupational Health, and there is a process for that. I hope that answers the question.
Yeah, that's right. I've actually, because I'm very early 50s, so I've actually just got a text from a GP to say to go to book it. So and friends, I guess it just seemed to be the AZ one now.
I think that's more often the case now. Yeah, there has been a shutdown's probably the wrong word of the Pfizer vaccine, but it's not being it's been kept back for second vaccinations. That's critical. That's a critical thing, really. Whatever you have as a first one, you should get as a second one.
Yeah.
Can I add to that? Yeah. So I think the regulation is still that if you have the first jab of whatever, you will have the second one of the same. Now, that happened to happened to me this weekend, actually. I had the first jab here in Stockport, and then I live in Swansea, so I got a notification from Swansea Health Board to have a vaccine. So I went there without checking the paper. Maybe it was my mistake. And then they realized that, oh, this is second dose. They thought this is first dose. I said, no, I had one in England. So they said, no, today is it's AstraZeneca, so you have to come back again in a week. So it depends on the availability. So the logistic of this magnitude, it's massive. This is what we are doing now, the government, and obviously we have to use even the army for that. This is a logistically very high profile campaign that require effort of everybody. So, and scientifically, although there is a research now to see whether you can have the second jab from different, so far the regulation of the country and science so far that you've got the first vaccine of Pfizer, you will have the second one the same. If you got AstraZeneca, you'll have the second. If you have got Moderna, you'll have the same, unless the research, which is still not come yet, telling us that we can have the first vaccine from first one and the second one. So far, you have to the same one. Now, if your worries, I presume we haven't asked, but if your worries regarding the AstraZeneca, regarding the thrombosis or clots, which I presume maybe that was in your mind, is it?
Well, actually, I am very, very hesitant of all medication, but even I did think that the clots information did seem, when I looked at the news, my understanding is there's fewer clots in the people who've had. I guess that's just, I have got a statistics background, so I'm not actually worried about the clots actually, but I do know people who've had the AstraZeneca vaccine, and some have said they felt quite unwell with it. So I guess I'm probably a little bit concerned that I could well have. I do feel extremely fit and well. I think I possibly have had coronavirus because my daughter is at high school, and I might not have because I only had a slight cough in October, so I don't think I have, but I might have had it. But I know some people who've had the AstraZeneca vaccine who have actually felt quite unwell. So I guess that's made me hesitate even more, really.
Yeah. Can I, let me just, now, Dr. Menzies have clearly, wonderfully explained to us the difference between so you got the Pfizer vaccine is actually, it's not the virus itself. It's at all. There's no virus introduced. It's what is introduced is a message, like a messenger, and that is not the virus itself. In AstraZeneca, it is attenuated virus, so it's a very weak virus. So they use the vaccine, the shell of the coronavirus protein. They took the protein that can recognize it and introduce it in a virus that it is very weakened, and then the virus itself comes to you. So that's why they're different vaccine, AstraZeneca comparing with the Pfizer. However, with AstraZeneca, I can give you a short answer. You will have more probability of having clot with Netflix than with AstraZeneca. Staying watching movies on Netflix, giving you more liability of having clot in your legs than the vaccine. That's a short answer.
Yeah.
I think just a final point on that. We probably would look at the vaccines now as broadly similar. There are some slight numerical differences. There's a slight difference in method of delivery of the mRNA into the cell, but it really, they're broadly equivalent. I would have no hesitation in having either of the types myself, and would recommend that to friends, family, and others, really. There is going to be some people who feel achy. Sometimes if you tell people that, they almost expect that to happen, but it is a recognized common short-term effect that you just don't feel so good for 2 or 3 days. But that's the trade-off versus really ending up in intensive care and being ventilated for weeks and longer. And that is a trade-off that most people would think is a reasonable one. They do recommend that you take sort of paracetamol or ibuprofen if that's your normal choice, if you feel achy or shivery. But I think to go to another point that somebody else made, that they were needing to work and have the vaccine, it may be possible to try and pick a time that it's a Friday afternoon, if you don't work the weekend or something like that, that you have the dose and you've got the weekend to have family look after you while you recover from any mild or other symptoms. So there are ways around some of these things, but yeah, I think the numbers are very much in favor of having it, and we do understand people are hesitant. That's quite normal, and it's appropriate to make sure you understand all the factors.
Yeah, I mean, I had the Pfizer vaccine, and it made me a bit tired, the second one, to be honest with you, but I was okay.
There's a bit of an expansion to the question on the chat, and it's saying, is there a reason why the AstraZeneca is more preferred for people with allergies? Can there be clarity over that?
Can I comment on that?
Yeah.
Yeah. The structure of the vaccine is different, and that's why I think there's something in the structure of the vaccine of AstraZeneca, which is called polyethylene glycol 2000. PEG, and that's included in about 1,000 drug that we take. So it's a common substance that they use in pharmacology and in vaccine production. So that itself can be sometimes, in some people, rarely they can have allergy to it. So if the people have allergy to that specific substance, polyethylene glycol, then preferably Pfizer will be the better option for them. But in general, the allergy to the vaccine is very rare. And unless you have a specific severe allergy to a vaccine before in the past that require you to have hospital admission, then the vaccine is still important and needed for you. But if you have the allergy and if you use the EpiPen, the adrenaline pen, then obviously you are not, vaccine is not preferred for you, then unless if you have very high risk of having it. So again, it's not black and white.
Can I correct one point? I think, Dr. Hamed, you mentioned the PEG or the glycol product. I think that one is in the Pfizer dose rather than the AstraZeneca. So Paul will maybe referee it, but I think it's an end product or a byproduct in tiny amounts still in the Pfizer dose. So that's why the AstraZeneca is preferred in those that have allergy, because allergy is common to this product, which is in many drugs, is in cosmetics and other everyday products that we either put on our skin or we eat. So that's why you could have met it before and become allergic to it. You can't be allergic to something that you've never met before, by definition, because an allergy is a reaction to something that you've met before and react badly to. So that's why this PEG, as a residual from production, it could cause some people to be having a bit more of a reaction with the Pfizer. Is that, have I got that right, Paul?
Yeah, polyethylene glycol is part of the formulation of the Pfizer vaccine, how it's made up. Now, there are, as Dr. Hamed has said, that is in many, many products and drugs. And people who have a history of allergies or allergies to classes of drugs, it may well be that that's caused by polyethylene glycol allergy without definitely knowing that. And so therefore it's recommended in those types of people that the AZ vaccine will be a better option. And it may even well be that if someone's got a particular history of lots of allergies and complexities in relation to allergies, that they may actually be managed in an allergy clinic and have the vaccination in a, if you like, a specialist facility to support that, really. But yeah, in answer to your question, the Pfizer has polyethylene glycol and is more likely to cause allergies.
Yeah, sorry, I said that. Yes, so that's why it's a benefit of having AstraZeneca now, better than Pfizer if you have this allergy, polyethylene glycol. So if you have that allergy type, if you're not sure, then obviously consult with your doctor. If you are seeing an immunologist already, it's better to see that. If you've got very severe allergy, then it's better to discuss that with your immunologist and GP before you having the vaccine. That's a safety as well. And that's in itself saying that we in the UK trying to be very careful about these things. We don't give it as a blank, black and white. There's a lot of gray area in between in certain diseases, certain conditions. So, but that's a proof that we are following the science, and we made precaution for people if we're not sure, and if we are sure, then we say that. And if the science change, the advice will change. So that's how it works.
Anila, I was conscious one of the questions that had previously been put to me was around, because I've maybe got a penicillin or nut allergy or certain foods, which vaccination should I have? And it's partially or largely been answered by Paul and Dr. Hamed there. But in essence, those people with multiple allergies are better to have the AstraZeneca vaccine. But those people with a single known allergy to a fruit product can have the Pfizer if indeed that's the regime that they're embarked on. And I think it's important to know there's no antibiotics in the vaccine, there's no food substances, people wonder about that, and there's no animal product in the vaccine, because that sometimes concerns some people.
Thank you, Dr. Menzies. Again, in the chat, there's just a question popped up asking, what's the likelihood of the vaccine becoming like the flu vaccine, in that we will need it every year? And does that mean then the vaccine doesn't actually stay in your body like the flu vaccine?
I'll jump in and say something briefly. I think it's likely that there will be further doses of vaccine recommended to us either this year, later in the autumn, or indeed next year. And yes, I think we will probably need to have at least an annual vaccination for us, because we think that the virus itself will change a little bit, and so the vaccine needs to change a little bit. And indeed, the manufacturers are already changing it. One of the great things about this particular process is they've already started modifying the doses for, if you like, the next round, because they're anticipating a next round, so that it's more targeted to the viruses that are circulating, the type of viruses. It is a virus that is not very clever, so when it duplicates, it is not very accurate, and that's why you get the variation. And that's why we're going to have to keep ahead of it, because let's say 80% of us take up the vaccine, it leaves 1 in 5 not doing so. They will continue to catch the infection and pass it round a bit, and the virus will modify. And we will also get different viruses from different countries as we start to, perhaps we hope, be allowed to travel in different places. Coming back, you will bring back different viruses if you haven't been vaccinated, or maybe even if you have, if it's not quite a correct match. So yes, we will need to continue to have, I think, it's not yet absolute, but it's likely to have a vaccine at least once a year, and at the moment they're debating whether to give a 3rd dose to people in the autumn after or before the flu vaccine. So it's a program that's running on. They're also talking about vaccinating the children shortly, if the studies are suggesting that's the right thing to do. It's not that the vaccine stays in your body, it's more it's teaching your body to fight the vaccine. Sometimes the body needs to be reminded, and sometimes it needs to be reminded in a different way by a slightly different vaccine.
Thank you. Any other questions from anyone? Or are there any questions from the panel members that you might have had that you feel we've not raised today that we're good to clarify?
Can I mention something about the difference? Yeah, regarding for people who are from Muslim faith, like myself. So the AstraZeneca one is the only one of the vaccine available containing a little bit of alcohol, but called chemical alcohol. And some of the Muslim might think that it might not be permissible for them. There was BIMA, British Islamic Medical Association, which I'm one of the founding member, and we issued a statement after consulting with the Muslim jurists and imams, that the amount of alcohol is so tiny, and it's a modified alcohol that doesn't make it impermissible. So it is permissible for Muslim faith. And the amount of alcohol in it is similar to the amount that alcohol present in the loaf of bread or banana that we take, which is the chemical, the minor chemical alcohol with food preservation. So it is permissible for people from that side. And as Dr. Menzies suggested, the vaccine have no animal product. So people who are vegetarian from that side, it have no animal product in them at all.
And just another question as well, Dr. Hamed, on that. So there was also some information circulating that there might be fetal product in the vaccination. You're just on mute, Dr. Hamed.
Yeah. So yeah, thank you for that reminding about that. Yeah, that is again history. And in the 60s, 70s, there was use of fetal cells to produce vaccine, but that is long time ago. In the current climate now, we don't use any fetal cell to produce the vaccines. So that is not the case nowadays.
Right, thank you. So just a final ask for any questions, otherwise I'll hand back over to Paul to give some final summary. Thanks.
could I just not ask a question, but make a comment that there was a bit of controversy about the timing of the second dose of the vaccine. Obviously, it was initially designed to be given out about second dose about 4 weeks after the first. And in part, that is because that's a common vaccine pattern. And in part, we wanted to make sure that we protected people as quickly as possible. And what we found is that the first dose in itself is very effective. So there's less criterion the need to rush the second dose. And the second dose's main aim is to keep that initial great benefit sustained for more months. So actually delaying it is not a problem. And indeed, it may be slightly more effective if it's delayed, but sometime within 4 to 12 weeks is the best time to have your second dose, but leaving it 10, 11, 12 is not a problem, and it's as good as, if not slightly better in some people, to give good lasting immunity. So just to close off that issue and concern that we weren't doing a proper vaccine program, but it is highly effective at a delayed interval.
I think that's really helpful, Donald. I think that might allay some staff concerns about that particular aspect of the vaccination programme. I think that's been I hope that's been a really helpful session. It's generated a lot of questions, and it was quite interesting because we had some questions we were going to answer, if you like, in case nobody asked any questions, and it was really useful because we were all getting ticked off as we went along. So I hope that's been good for people to listen to, and I know this is going to be recorded, and again, I hope people find it informative. Obviously, we're still doing vaccinations. They're now going through, the first vaccinations are going through Occupational Health with the AZ vaccine, and the vaccination programme at Pinewood will focus on second vaccinations. I'd like to thank everybody for their involvement in this session today, particularly our speakers who've done a sterling job, so thanks everybody, and thank you very much.
Helen, do you want to say quick something about the Facebook Live sessions for anyone who missed today?
There I am. Thanks, Anila. Yes, we will be running a Facebook Live session from the end of next week. There's details out now on the weekly updates that you'll be able to find more information on. So if you've got any more questions, you can post those on there and we will be answering them over the next few weeks. So please have a think and rack your brains, because I think today's been really useful in terms of getting to the bottom of some of the worries and concerns that people have had, to be honest with you. So yes, we're looking forward to doing a lot more of this. We'll also be posting this video onto the staff Facebook group and through the intranet as well, so that you can play it back if there's anything that you missed or you'd like to go through again. Thanks, Anila.